Okay, so last time we left off talking about inequality in the USA and specifically about how this relates to COVID. So I just want to remind you where we left off last time, which is trying to think about this idea that you may feel comfortable taking risks for yourself, but the question is really, are you comfortable with what that might mean for other people, the effects that your actions might have? And then trying to think about what privilege you have to reduce transmission within your community. That's going to vary person to person, right? So some people are going to have more ability to do that than others. So in thinking about those ideas, we're going to talk about some of what we know about inequality related to COVID. So in this pandemic, we have seen racial inequalities in health, wealth, and many other areas exacerbated. We also know that immigration has been an issue for people being able to get treatment. It limits the ability for people to safely access services, which has been a huge problem. I'm going to go into more details about all of these things, but this is kind of an overview. We also know that there are generational wealth gaps that are exacerbated by the pandemic. A huge number of people lost their jobs and suddenly did not have money to pay rent. Obviously, if you have generational wealth that has allowed you to buy a home and you don't have to worry about rent, that makes a huge difference in a pandemic like this than if you're living paycheck to paycheck paying rent. We know that there was a big issue with homelessness and also people having lack of access to a safe home. So, you know, if you have when we closed campus in the spring, some students had a safe home where they could go live during that time, but other students did not. There are students who don't have homes, right? There are students who are orphans. There are students who face violence at home, who don't feel safe in their homes for a variety of reasons, including sometimes because of their personal identity. So there's a lot of variation in issues that people face in this pandemic beyond just whether they get infected with COVID or not. Some of that lack of access to a safe home is also related to LGBTQ+ concerns, especially in college populations where students have gotten to leave home and maybe had the opportunity to express themselves in the way they would like, and then were forced back into a situation where they weren't able to be themselves, even if maybe there wasn't physical stress in the home or physical violence in the home. There's a lot of mental health concerns around that. There are huge gender inequalities that we've seen play out in this pandemic. Of course, we know that there are inequalities in pay and job loss and responsibilities at home, but in this pandemic, disproportionately, those issues with loss of pay, loss of jobs, and increased responsibilities at home fell on women. Disability concerns were also a major issue. In fact, they often weren't even addressed. So people were so focused on the racial inequalities, the economic inequalities, the gender inequalities, that there was very little attention paid to disability concerns. And yet, those are things that are very much an important aspect of how you deal with a pandemic that obviously is closely related to our healthcare. So, there are some people that have disabilities that require them to get regular medical care. And we were at a point in certain places at certain times during this pandemic where hospitals were full and were unable to provide care for people. So what happens to people with chronic illness, for example? We also saw a lot of issues for people who were caring for children, or people who were caring for elderly parents, also people caring for each other. There was added responsibility, whether you were taking care of someone who was sick, whether you were taking care of an elderly relative, or taking care of children, that did not equally impact everyone. And then, of course, the pandemic has been a time of loss, of long-term illness, of death, and of death of loved ones. And that has not been equal either. So there are people who have been very personally touched by this virus in that they have personally suffered health consequences from it, and or they have lost loved ones. And I think that many people who have been guarded from having that personal experience forget that that's happening, and sometimes say things that are really inconsiderate if you do take into account the fact that that's happening. So one thing that I want to stress, and that I've already said in this course, but you'll hear me continue to say, is that in this pandemic, we must show kindness to each other. This is a very difficult time, and even if you feel like you're getting through it okay, it's likely that other people around you are struggling with one issue or another that you may or may not be aware of. So show kindness to each other. Mental health issues are a serious concern. We will be having another lecture on mental health issues. We had one last time in this course. We'll have another. There'll always be something that we're including in the discussion because we need to be concerned about both our physical health as well as our mental health. And as Dr. Ennis will talk to you about, this pandemic is continuing on, making those issues with our mental health grow exponentially. And so we need to be thinking about that, and also the fact that those issues do not hit everyone the same. Isolation is very dangerous. It can cause cognitive decline. It can cause mental health issues. And yet we're in a situation where many people are in isolation. And being part of this WashU community, for those of us who are in St. Louis, many of us, not all of us, but many of us have the opportunity to not feel totally isolated. But there are other people who are. My mother is one of them. I've been extremely concerned about her. She lives in an area where people are not being safe. She doesn't have good options for socializing with people in a safe way because her social network won't get on Zoom, and they won't do a distant masked, visit. They go to restaurants and they eat in restaurants, and it's been a big struggle. She's been very isolated. It's been a really difficult thing, and she lives 8 hours away from me. So, these are issues that people are dealing with. Your classmates may be dealing with these issues also with their loved ones. I would encourage you to be creative about finding ways to connect when you can. We'll talk through some of those options in this class. It's cold out now. People were really struggling with the winter coming, but even though it's cold, we can still get outside, find ways to do things safely. We can try to connect digitally over the computer. We can also try and connect through the mail and in other creative ways. Try to what extent you can to try and get into a good mindset where you accept the situation that we are in, and then you try and find these positive experiences that can be a part of it. So, for example, I've been saying to people, bundle up, get outside with a friend, reframe how you approach winter. This is something that I've seen. I did some work in the Arctic, very close to the North Pole, actually, in very far north Greenland. And when I was there in the summer, it was much colder than it is here in St. Louis right now. And it was summer to them. So everybody was out enjoying themselves. And they are used to the cold. So they even when the weather is cold, they're still very active. They layer up, go outside. That's just the mind frame that the people in the community where I was working were in. And so I think we need to take a similar approach to that, getting into that mind frame. And I think also just having a long-term approach. We are not out of this yet. So, it will take a long time for vaccine distribution to be completed. And so we need to keep working towards being safe, reducing transmission so that we can make it through this year, and really wrapping our minds around that. One thing that I'm very worried about, and if you're anyone who works with me or in my lab, you've heard me say this, I'm really worried about the people getting so hopeful about the vaccine that they make plans for April, and April comes and it's not safe to do whatever those plans are. It's a lot harder to cancel plans that you made than to just not do something that you weren't planning to do anyway. So, you know, that it's a super hard thing. We're going to be working through that all semester, trying to figure out how you can try and have both positive, to what extent you can have mental health and physical health during the pandemic. And you know, this class is meant, at least in part, to be a community that you can connect to. So I hope that you will use it in that way. I know that the first class ended up being a good opportunity for people to connect, and I hope that this one is as well. Okay, so think about something that we've heard so many people say over and over again: no matter what the issue is, try and do what you can to stop transmission in your community. That will help with all of these issues that I've just summarized. And keep in mind also that empathy is powerful. Empathy is often described as something weak, but it really is powerful. And with it, we can do some really great things in the world. So practice that empathy. One of the speakers, so last time we were talking about information provided by Dr. Wang and Dr. Jimenez. Dr. Wang had said, you know, that the things we can do as individual citizens to help the most is do our part to reduce transmission, because that helps everyone. Even if you and your friends don't get seriously ill from the virus, reducing transmission among your group will reduce the eventual transmission to your grandparents, for example. So doing it for the common good. Also, Dr. Jimenez had said, if you see something, but say it politely. So have those hard conversations with your friends, your family, about avoiding risky behaviors. Say something, for example, if you see one of them not wearing a mask or hosting parties. But remember that you don't know what every person on the street is dealing with, right? So, you know, while you want to encourage your networks, you don't want to be policing people on the street. Those are two very different things. And having compassion, showing kindness, those are all very important as a part of this too. So try and have a positive impact on your community. And you know, there are ways to encourage good behavior without having it be stigmatized or punishment, those sorts of things. So again, I just want to emphasize the role empathy can play. This is something that has come up a lot in discussions of the pandemic. Remind everyone to show kindness, and just remember that over and over again, what we have heard is that the best thing that you can do to help everyone disproportionately impacted by this pandemic is to do your part to reduce transmission. So I'm going to keep talking about those disproportionate health impacts, add layers to some of the things that we know from last year. And I want you to keep in mind that in this course, we're combining information from a lot of different fields. So we want to understand the COVID-19 pandemic as a whole. That is more than just medicine, right? I mean, this pandemic has had impacts on every aspect of our life. So, you know, there's aspects like we were talking about with the work of Dr. Wang and Dr. Jimenez, that's hard science where, you know, we're looking at the virus itself, the illness it causes, talking about the medical science behind things. But it's also really important that we include social science, journalism, a lot of other fields to try and understand the cultural context in which this pandemic is happening. And in this course, we want to provide you information that helps you understand the current situation. So, you know, you may feel frustrated that some people don't wear masks. So let's put that into context. We want to help you with what's going on right now, but we also want to impact the way you think about these things in the long term, right? I mean, I often say students at WashU are incredibly talented. I am positive you will all be very successful in whatever you choose to do. And so I think to the best of our ability as much as we can cultivate like better understandings of what's happening in the world and how it could be handled better in the future, will help to make sure that when you all are in charge of dealing with the pandemic, because unfortunately, that's probably going to be a thing that happens in the future, that you have these ideas in your head, right? Like I don't think that by telling you about Missouri's tier system for vaccine distribution, we are going to actually change the tier system for the vaccine distribution in Missouri. But I think that some of you may one day be involved in trying to figure out vaccine distribution for a new illness. And so, thinking about these issues is important not only for today, but also in how we understand the world and how we do things the next time. That's what your education is, right? It's just trying to get a better understanding of everything going on. Okay, I also wanted to just take a minute to position myself, because you may get sick of me over the course of this semester telling you to be safe and be kind. And you might think like, this lady doesn't have a life and she's just like so fine to sit at home and not do anything. And that is not the case. Maybe I don't have a life, but I do a lot of things. So I travel a lot internationally, actually. And so this has been a huge change to my life. This is by far the longest time I have ever spent in St. Louis, and the longest time I haven't traveled internationally in a very long time. And I had a bunch of plans on March 6th, I had planned a vacation in northern Italy that was, driving up through the Alps and things like that, and then back down to Rome to fly back out for our spring break. So I was supposed to leave on March 6th. I mean, I was supposed to be in the current COVID hotspot at the time that it was the hotspot. So I had to cancel that. I had 4 research trips planned, Madagascar, Uganda, Kenya, Ecuador, all that had to be canceled. And you know what else? I was supposed to go on my honeymoon in the summer. So like I have things that I would love to do still, as all of you do. So it's not as though people who are pushing for you to be safe just don't have anything better to do with their time. We really want to be able to do those things, right? And so we're trying the best we can to get to a place where that can happen. I also struggle with the fact that my family, like many of you who are here on campus and not living near your family, they're spread around the United States. So getting to them is difficult. And I'm also an extrovert, so I'm not used to staying home and not talking to people all the time, which might be why I keep teaching these classes with hundreds of students. Not really, but I mean, this is a big adjustment. And in saying that, I also want to point out to you that the things you are feeling are totally valid. This is very difficult. Whether you're an extrovert or an introvert, you're from St. Louis, you're from far away, you like to travel, you don't like to travel. This is hard, and it's changing who we are. And that can be a difficult thing to grapple with for anyone. I think it can be particularly difficult for students at your age, where maybe some of you are dealing with living outside of your home for the first time. Some of you are dealing with living in your own apartment for the first time. Some of you are dealing with living with roommates for the first time. There's a lot of changes going on. You may just have realized what you want to do for the rest of your life. All of these things that it's probably hard to try and figure out, what is this feeling I'm having? And is it related to the fact that I'm in a pandemic? Or is it related to the fact that I just started university, or I just moved into my own apartment? So, I think one thing is that trying to acknowledge those feelings that you're having and work through them can be very useful. That's one of the things that we're going to do when we talk about mental health. And so I want to tell you that the pandemic itself, despite everything else that you're dealing with, the pandemic itself is changing people. I say I'm an extrovert. So I am such an extrovert that I will, if I have a long layover somewhere, which I often do, I will leave the airport. I will deal with all of the security, sometimes even like getting a passport stamped and everything else. So I can leave the airport and see whatever friend I have in that city. And then like go through all the security and stuff again to get back into the airport to catch my connecting flight. That's something I used to regularly do. In fact, a year ago, a friend was just sharing with me a picture from a year ago when I was flying back from Uganda, and I left Atlanta. We went to a brewery, we hung out, we had a picture taken. She sent me the picture last week and was like, remember a year ago when we were socializing? And that was, I mean, I just like craved seeing my friends so much before I was locked away from them even, that I would do things like that. Now, socializing feels very draining for me. You know, it's a phenomenon that introverts talk about a lot. And I'm experiencing that now. And it's strange because I'm a full-grown adult. Like I know what my personality was before. And so I can tell you that some of the things that you are feeling, those are directly the result of this pandemic. They're not you having a hard time adjusting to college or having a hard time, you know, working out personal relationships with your roommates. This pandemic has had big impacts on us, and it is having lasting impacts. That's something that Dr. Ennis will be talking to us about. So it is not just you. It's not just adjusting to campus. It's not just adjusting to whatever other changes you've had in your life. This is a difficult time, and I'm not trying to downplay that by just telling you to follow the rules. You know, I acknowledge the struggle that everyone is going through, and I hope that we can create a community here to try and deal with all these things together. Okay, so some of you asked in your questions some version of the question, what do you say to people who want to return to normal? Whatever that is, you know, and I think that this topic that we've been covering is really what we need to think about. Inequality that is happening. If we are at a point in our lives where we haven't had to deal with a lot of these really tough things, and so we just want to stop wearing masks, and we just want to get together with our friends, like it's not that big of a deal, let's just do it, it'll be okay. I think I remind myself of what's happening in certain communities in our country. So this figure is old. I'll show you some different dates and figures throughout this lecture. But in May of 2020, they had recorded 100,000 deaths from COVID-19 in the US. 48.1% of those were people of color. And that number has definitely increased since May. However, much of the early media coverage focused on white patients and white medical workers. And this is something that people have talked about a lot as we've kind of looked back at those early days. And that focus on white patients and also the way that we were treating people is part of an ongoing narrative within medicine where white patients and non-white patients are treated differently. So this is from a study in 2016 from the Proceedings of the National Academy of Science, where they looked at white medical students and white practicing physicians and asked them questions about their patients and how they were treating them. Half of white medical students and practicing physicians believed that Black patients did not feel pain as acutely as white patients, and that resulted in them providing less accurate treatment recommendations for Black patients. So this issue of health inequality, racial health disparities has been an issue, forever. I would say for a long time, but forever. And part of this is related to implicit bias. Now, with implicit bias, it's important to recognize that it exists. It doesn't help if you try and pretend like it doesn't exist, but rather recognize that and then try and deal with it appropriately. And part of that, what that means is having diversity, equity, and inclusion in every space where we are dealing with these issues, because that representation really matters. And trying to make sure that we are actually dealing with all of the patients and all of the people that need help in these different ways. So one of the reasons that initially there was this focus on kind of wealthy patients is actually because the trajectory of this illness was a bit different than a lot of other outbreaks that we've seen. The global spread of COVID-19 was facilitated by wealthy people traveling, right? So some of you asked questions about like, well, in 2003, why didn't SARS spread as quickly, or why has this disease spread so quickly when we've been traveling by plane for a long time? It is true, we've been traveling by plane for a long time. Have we been traveling as extensively, as frequently by plane as we do now? No. So that's part of what added in layers, but obviously the actual virus itself and the way that it spreads was an issue. So we had this global spread, people going on business trips, study abroad, vacations. You know, if I had gone to Italy, I could have been part of this disease vector situation. And then all of those people who have the ability to travel then brought that back into their communities. And within the communities, they were relying on various portions of the service industry. And that then caused the virus to quickly spread throughout local communities. And so, you know, you had people who brought it into those communities, then it spread. And those communities of service workers are people who don't have good access to healthcare, don't have the ability to take off work when they feel sick or when they may have been exposed. And so then you ended up having this disproportionate impact on those communities, which is what we have continued to see happening in the United States. There's a great book out recently by Mark Lamont Hill called We Still Here. And he says in that book, social distance is an index of privilege. And it is. Not everyone has the ability to stay distant, to not go into work, and so on. So we're going to be talking through some of those specific numbers. In that book, We Still Here, he discusses the issue that African Americans account for 60% of the dead in this crisis at the time of this writing, which was later in 2020. Sorry, pointing at the book and I'm knocking things over. And yet, even though it's 60% of the dead, African Americans account for 13% of the overall population in the United States. So this is what we mean by disproportionate impacts. There are layers of vulnerabilities, as I started to talk about last time, that are part of the reason we see these numbers. Yes, there is the lack of access to healthcare and treatment. There's also less ability to work from home and less ability to avoid people when you go to work while you're at work and also on your commute to work. You know, if I need to go to my office or my lab at WashU, I can get in a car, drive to my private office or my private lab and not be in close contact with other people. Whereas many people are going to work in places where they're in close contact with other people and they're taking mass transit to work. So 20 to 25% of Black and Latino people use public transportation to get to work. That is an additional layer where they cannot keep themselves distanced from other people. They are also less likely to own a home and may be in situations where they're dealing with crowded living conditions. We also know that pre-existing conditions are linked to poor COVID-19 outcomes, and those same conditions are linked to environmental racism. Environmental racism is something that was an important topic of conversation prior to COVID-19, but now it has really become an important focus because we see the links to poor health outcomes. So environmental racism increases your likelihood to have the following pre-existing conditions: diabetes, asthma, other respiratory disorders, and there's a lot of other things, but you may recognize those first three also as being on lists of pre-existing conditions that make you more likely to both contract and have poor health outcomes from COVID-19. If you're interested in environmental racism, I really recommend a book called A Terrible Thing to Waste, Environmental Racism and Its Assault on the American Mind by Harriet Washington. It was published in 2019, but there is a version of the book now that has a preface that was written last year. And in that preface, they talk a lot about environmental racism and how that directly overlaps with issues concerning COVID-19. Another part of the vulnerability that these communities face is trauma, both from personal experience and institutional racism, that makes it more difficult for them to get access to the care that they need. And that trauma is part of, or the result of, a distrust between certain communities and healthcare providers. So I want to, in addition to thinking about this from the perspective of Black Americans, which we heard some stats on, there's also the issue of the Latinx community. So within the Midwest in particular, which obviously is where St. Louis is located, you have a lot of Hispanic and Latino people working in the poultry and meatpacking industry. And during COVID-19, these places stayed open. Prior to the pandemic, they were already known for being a hazardous working condition. They're dangerous, their people are very close together. So even under the distancing orders, people were not being spaced out as far as they needed to be. And not only were they staying open, but they also were told that they needed to operate at high efficiency so that we would not have national food shortages. In other words, we felt that these workers who work in the poultry and meatpacking industry kind of needed to do what needed to be done to provide food for the rest of the nation, right? So that there wasn't a food insecurity or a national food shortage. There are some things about disposability that I hope to talk about, people being disposable, that I hope to talk about later in the course. So for example, Tyson Foods has had over 10,000 employees with COVID-19, and there's lots of other concerning facts about the meat and poultry industry. And then even layered into these workers who are forced into these conditions, you have differences in privileges between documented and undocumented immigrants, right? So even when we're looking just within the US, just within the Midwest, even when we're looking just within the Latinx community, within the poultry and meatpacking industry, you have this difference between people who are documented and therefore can, to some extent, access healthcare, and people who are undocumented and cannot. You also may recall that there's these big issues with what do you do for children who are supposed to be getting homeschooled and their parents have to work outside the home. Well, in addition to that, what do you do about students who are supposed to be homeschooled and their parents don't speak English? So, you know, a lot of schools started relying heavily on the home being the classroom, and that gets very complicated if students are supposed to be completing assignments in a language that parents do not speak and therefore cannot help complete those assignments with their children. Related to that language issue, there also has been a big lag in the translation of health messages to other languages. So by the time we were all so sick of the term social distance, it was only, you know, starting to be translated into other languages in order to share that really critically important information with people who don't speak English within the United States. And then that also means that when those people go to the doctor, they may not understand the interactions at the medical care facility where they are. And a lot of times translation services are not available, or if they are available, it's after some time, and that really misses that critical window of which, you know, you could be sharing information with a patient and helping to make sure that everything that needs to be done for that person and their community to be safe is communicated in that meeting. So I think it's important for us to keep in mind that when we're talking about accessible healthcare, that doesn't just mean is there literally a doctor's office nearby, but it's also thinking about what are the interactions that people are having there. Are they able to speak to the healthcare providers? And even if they are, how are they treated? Is their pain dismissed as not being real? Are they not provided the most accurate treatment because of their identity? Do they leave feeling shamed or confused or thinking, I can't go back to that resource because they shamed me or made me feel confused? That's not accessible healthcare. So the layers upon layers of issues that exist in actually dealing with the implicit bias within our medical community and our country at large, and actually getting people the resources that will help us all in this pandemic, that's been a very difficult issue. So, you can look at these people who are working jobs that they have to go to in person, who are taking mass transit to their jobs, who are living with many people who don't have stable homes, all of these things, those do not solely break down by race. It is also an issue of poverty, right? So we're talking about vulnerabilities and we have this issue of poverty. So my question to you is, then is really the point that the issue is poverty and not race? And we're gonna try something here. So you have to understand that for a class this big, it's complicated because WashU doesn't, we have to use a special license for this Zoom, blah, blah, blah. I know you all have great suggestions for how we could streamline the Zoom calls, but the reality is that it's actually quite cumbersome with this many people. So we're gonna try a poll, though the licensing around the poll for a class of this size, it turns out is complicated. So please, when the poll pops up, please answer the question, is the issue poverty, not race? So it's gonna be true, false, is the issue poverty, not race? Rose, can you please share the poll? Great. Okay, so go ahead and answer, please. Few more of you need to vote. Those of you that are just showing up to class, please make sure you vote in the poll. Just gonna give you 5 more seconds. Okay, thank you to those of you who are paying attention, that's great. All right, so if I hit share results, can you all see that? Can people see that? I can't tell if people can see it. I'll share with you the results. It's that 35% of you said true and 65% of you, oh, you can see it, great. 65% of you said false. So, oh, okay, I think, can you now share my screen, see my screen currently? Can people see my slides now? Hopefully. Yes? No one's answering that. Oh, wait, you're answering. Okay, great. Yes, okay, great. Thank you. Okay, so some of you put in the question and answer like, but poverty is part of, generational wealth gaps and racism and whatnot. That's true. So yeah, the issue is poverty, not race. That's actually false for several reasons. One, which some of you identified, is that poverty is not separate from race, right? There are institutional issues that create this issue in poverty for people of particular races. But also, even if we look within a given socioeconomic class, if you are not white, you fare worse than other people in that same socioeconomic class. So COVID-19 infection and survival is linked to economic vulnerability. That is true, regardless of race. But, so in other words, that means if you are poor, you have worse outcomes for COVID-19 than if you are wealthy. That is true across the board. But For Black, Indigenous, and other people of color, they are disproportionately vulnerable when compared to whites of similar economic conditions. And I'm going to share a quote with you in a little bit from Dr. Essien, who talked about, how this issue of race really plays out in the medical world as resulting in poor health outcomes, regardless of whether you are impoverished or not. And there have actually been some kind of famous examples of that, right, among wealthy people. So how can you help? So Dr. Julia Lopez, who is with the Washington University School of Medicine, suggested that whenever you leave your home, whenever you're interacting with the world, ask yourself, how am I interpreting the world around me? And am I pushing a prejudice I have on someone else? And then notice those thoughts, reflect on them, and think about changing how you do that next time. It is work. That implicit bias is something that we all have. And so we need to challenge ourselves on it. We need to work towards changing it, because I know a lot of you are pre-med. And so when you are treating your patients, you will be able to reflect on this practice that you have been doing ever since undergrad, and hopefully really change the way you're having those interactions in the future. Dr. Utibe Essien had said that if you were African American in the US, you are more likely to die regardless of your wealth and education. And he himself talked about his experience as a Black doctor who has faced these issues of mistreatment despite the despite the education that he has and the secure position that he has in our society. So race is absolutely an issue, and too often people, this has been one of the misinformation points that has been circulating during the pandemic is some particularly, powerful individuals have really tried to say, this is not about race, this is about poverty. And that's simply not true. Okay, so I want to give you an example of this, and it relates to some work done by Ali Elabedi. That should say Dr. Ali Elabedi, but anyway, on antibody treatment development. This little symbol with a 3, that's how we used to make hearts when I was a kid. So that's not something you need to write down. That's just me being in love with the antibody 2B04, which is part of the antibody treatment that Dr. Elabedi talked with us about last semester. So here you can see that for treating COVID-19, a combination of 2B04, which is this first line that declines sharply when administered, and then 2H04, which is this blue line out here. This antibody cocktail actually showed a lot of promise in being able to treat COVID-19, and even to be given as a prophylaxis to try and prevent illness and poor health outcomes from COVID-19. Okay, so there we go. Dr. Ali Elabedi, he talked to us about the possibilities of 2B04 in combination with 2H04 in August and September of last year. And then in October, so a month later, then President Trump became sick with COVID, and he was immediately treated, you may recall, with an antibody cocktail. And hopefully anyone who followed the pandemic course was like, I know exactly what that is. And you may recall that he had a pretty incredible response to that treatment. This is a screen capture of a tweet that he shared that says, I will be leaving the Great Walter Reed Medical Center today at 6:30 p.m., feeling really good. Don't be afraid of COVID. Don't let it dominate your life. We have developed under the Trump administration, it's true, it happened while he was president, some really great drugs and knowledge. I feel better than I did 20 years ago. That's like quite the commercial for an antibody that I already was in love with, right? So 2B04, 2H04, these are examples of antibodies that were shown to really be effective in treating COVID-19. And then Donald Trump got this antibody cocktail. He did really well. Now, of course, there is a concern about the fact that at this same time in October, over 200,000 people had died in the United States from COVID-19, which is upsetting given that apparently you can feel better than you did 20 years ago if you are given treatment compared to being dead or having long-term health effects. So, I just want to remind you that these are the data for leading up to that time period. So he was diagnosed on October 2nd. So this is leading up to his diagnosis. This is Hispanic or Latino, non-Hispanic Black, non-Hispanic American Indian and Alaska Native, non-Hispanic Asian or Pacific Islander, and non-Hispanic white. Okay, that's what we're looking at along here. And again, you can see that this is, for this in particular graph, it's hospitalizations. You have much higher, much worse outcomes for Black, Latino, and American Indian and Alaska Natives than you do for white Americans in particular, also Asian Americans. I'm going to talk about that in a second. So, there is a privilege issue here, and we need to be aware of that. I also want to note that it is not, in a lot of these graphs, it looks like Asian Americans are doing great. And while that does seem to be the case in terms of health outcomes, Asian Americans have suffered a lot due to racism during COVID-19 because of it originating in China. And then, there already being existing racist sentiments and messaging in the United States, and it kind of building on that. So it is, I do not want these numbers that are specifically about hospitalization or death to undermine the fact that Asian communities in the United States have also suffered during this pandemic. Okay, so we have the stage set, all of this information about inequalities. And so I want you to be thinking about really how you critique information that's given to you, how you try and understand the information that you're being provided. And one of the ways that you will be accessing information in this class is through research articles. So you will also be listening to podcasts, you'll be reading popular pieces, but you will be reading research articles. And so you were meant to read a piece today from Jennifer Raff about how to read those research articles so that hopefully you can do it in a way that really helps you understand them. And part of the issue is that we're in a situation where we have information overload. Even the publications that are coming out about COVID-19 are coming out by the hundreds and thousands, right? So I want to encourage you all to read all of the information that you're reading with a critical eye, and that includes peer-reviewed publications, because they also don't always get it right. Last time in the pandemic class, I gave an example of an article that found support for hydroxychloroquine as a treatment for COVID-19, but it only found that was if you actually read the article and not just the abstract, it showed that that was only a useful treatment or only found positive results after they excluded treated patients that got very sick or died. They weren't in the follow-up test because they were dead or no longer enrolled in the study. Some of them were on ventilators, so they couldn't get a swab of their throat. A similar article that came out related to COVID, just to give you another example of what you want to be looking for, is this study about what species we may have contracted COVID-19 from. And in this study, what they did was looked at the genetic sequence of SARS-CoV-2 and compared it to different hosts. So you'll see here that there's hedgehog type things, there's humans, chickens, bats, and then there's some snakes here. And so they lined up the genetic sequences and they were looking at what the similarities are between these. And what they found was that the SARS-CoV-2 genome was most closely related to the two snakes that they had used. And so they argued that COVID-19 was transmitted to humans from snakes. Now, this one I think is kind of difficult. If you read an article about people being treated with hydroxychloroquine and they say like, well, some people died, so we didn't count them. You critically thinking, you can say like, that seems like a problem. Probably this article isn't good. This one's a little bit harder because what they were doing, the methods were all very heavy science jargon that if you don't study genomes, you wouldn't necessarily understand. But if you think about how we try and study viruses and viruses that move between humans and other animals, and even if you looked at the other studies that people were doing to try and find a match between SARS-CoV-2 and coronaviruses that exist in bats or in pangolins or in other animals, you would notice that what they were looking at was actually the SARS-CoV-2 virus compared to the virus in bats, the virus in pangolins, right? They weren't looking at SARS-CoV-2 in comparison to the host genetics of a bat and the host genetics of a pangolin. This paper, however, did. It compared the virus genetics to host genetics. And so, you know, the virus, it turns out, is more closely related to snakes than to bats or chickens or people. And yet, you know, other scientists spoke out against this, saying they have no evidence that snakes can be infected with COVID. They can't even be infected, right, to serve as a host. So it's not consistent with the idea that like we would have then gotten COVID from a snake. So pay attention to the details. The details are really important. And I think that that's something that the RAF piece that you were assigned for today really helps you to think about. So let's walk through some of that. So in that paper by Jennifer Raff, you think a little bit about how you read a scientific paper, right? So at the beginning of the paper is the abstract. The abstract summarizes everything that is in that paper. As beginners, it is common for people to want to read the abstract because it'll give you an overview of everything in the paper. So I have this question for you, and we're going to try our poll situation again. When reading a scientific paper, should you start with the abstract, true or false? Rose, can you please share the poll? Okay, go ahead and start. Should you start with the abstract? Sorry if you hear me swallowing my water. Okay. Let's do 10 more seconds. All right, so I believe you can see this. 38% of you said true and 62% of you said false. The answer is false. So when you read abstracts, they are the summary that the writers are providing for you with the take-home messages, and they don't include all of the very important details that you need for trying to critique that paper. So you should not start with reading the abstract. That example that I gave of the hydroxychloroquine paper is actually just the best example of that you can imagine. Some people had asked in the questions, how do you evaluate the source that you're reading? One thing that you can do for peer-reviewed papers is look at something called the impact factor. That'll tell you like how highly rated that journal is. That sometimes can be a good indicator. You can also look at how many citations a piece has, except you have to be careful with that because, for example, that hydroxychloroquine paper has a ton of citations, thousands of citations. But the reason it has so many citations is because a lot of people used it as an example of problems with reporting on COVID-19. So you want to actually look through those citations and see if there are people who are using the basis of this work as a basis for their own work, or if there are people who are saying, by the way, this is a terrible paper and it should not be believed. The other thing when you're looking at these papers is that you want to be a critical thinker. You want to read the details, not just the abstract or the headline. So for that, hydroxychloroquine paper. This is the abstract, right? It gives you a little background, it gives you a little debrief of the methods, and then it says, conclusion, despite its small sample size, our survey shows that hydroxychloroquine treatment is significantly associated with viral load deduction / disappearance in COVID-19 patients, and its effect is reinforced with azithromycin. Okay, if you actually read the paper, you will see that 6 patients, literally 23% of their patients were not who were treated with hydroxychloroquine were not included in the analysis. 3 were admitted to intensive care units and put on ventilators. 1 died, and 1 discontinued the treatment because of side effects, which were nausea, and 1 left the hospital. And because these people were intubated and couldn't provide a sample, dead and couldn't provide a sample, stopped taking the medicine and therefore couldn't be included, or were just gone so they couldn't provide a sample, they were excluded. I think that if you recalculated the statistics for this paper, including people that had such bad health outcomes while being treated with hydroxychloroquine that they were not able to be included in the study, would probably affect the results. That is not something you will see in the abstract. That is something that you have to read the paper to get to. So please make sure that you are reading the papers. Okay, so now for the last 15 minutes, I want to go through some questions that you asked and also just kind of answer some questions about the course overall and things that we were talking about last time. So some of you were asking questions that are things that we're going to be covering in entire lectures. So I'm just skipping right past those because I know we'll get to them in the future. You know, we're going to have entire lectures about vaccines. We'll be talking to the deputy director of the FDA, who's in charge of vaccine development. So those questions will be handled in the future. So I'm skipping over some questions. I'm also using the time that I look at questions to be an opportunity for you to kind of catch up on where we're at and think about what we're talking about. One vaccine question, though, that I do want to address is someone asked, why does it matter when people get vaccinated if we just want to reach herd immunity? And hopefully the lecture today kind of answered that. But the reality is that people are still dying and people will die waiting to get the COVID-19 vaccine. That is the horrible reality of the situation that we are living in. So, you know, vaccine distribution is going to take a long time. It's going to take probably this whole year, the better part of this year, to reach the level of herd immunity that we're told we need to reach. And that, you know, there are a million question marks in the air because we're not really sure how many people, how quickly our vaccine distribution will be improved, because right now it's not that great. So it's going to take a long time. And in that time, people can get COVID, they can get seriously ill, they can have long-term health effects from it, or they can die. And so that's why people think about how to distribute the vaccine. I also want to come back to the case of India because, you know, anecdotal evidence, anecdotal experiences with things like pandemics are very important. They are important, but they also can be difficult. Like the anecdotal experience of someone in New York City in March was very different than the anecdotal experience of someone in rural Missouri in March, you know? And so we have to try to what extent we can to get reliable data. And I agree that there is an issue with having reliable data for COVID. So the figures that I showed you last time were from the New York Times. And so I went ahead and looked through different places, BBC, Al Jazeera, World Health Organization, et cetera, to try and see what other people were saying about India's COVID situation. And the World Health Organization shows a similar pattern in which there was this peak in the fall, and then this decline, this continual decline since that time. And other places that I looked showed a similar trend. And in fact, this is a situation that not only are the numbers suggesting this, but it's something people are talking about. They're talking about how did they get here? What are the dangers still? You know, as part of the way they did this was really serious lockdowns that had some of their own problematic repercussions. But what happens when they no longer enforce lockdowns? Then what will the numbers be? Things like that. So overall, while we certainly cannot say for sure what the counts are or how reliable data are from anywhere, this image of the situation getting very bad in India and then getting better is commonly what is being reported from the organizations that are meant to be reporting it. Also, Science had an article in October, the end of October last year, said India's COVID-19 cases have declined rapidly, but herd immunity is still far away, scientists say. And so again, there are a lot of different scientists and health organizations that are suggesting that in fact there was a very rapid decline in COVID cases and deaths in India. That article goes on to say that a leading panel of scientists appointed by the Indian government delivered a startling optimistic message. The world's second largest COVID-19 epidemic has rounded a corner. India's daily number of daily new cases has almost halved in the past 6 weeks. And I've seen discussion about the lockdowns. I've seen discussion about the population demographics. I don't think that people know entirely if this will hold, or if, how it came to be. I think one thing that Indian scientists are saying is that they were lucky in that they did not have this increase in cases until about 3 months after other places did. So they got to see what other places did well and what they didn't do well. And then they based their response off of that. Maybe that's true, or maybe it's not. But there was a comment about concerns about variation in testing, and that is true everywhere. That's true in the United States. We've had big concerns about the quality of tests happening. There are a lot of different types of tests. There are different people administering the tests. There are concerns about the quality of the data, not just coming out of other countries, but coming out of the United States. The New York Times says that official tallies in the United States and in more than a dozen countries have undercounted deaths during the coronavirus outbreak because of limited testing availability. So I agree that that we must take these numbers with caution, but that is not just the case in India, it's also the case in the United States and elsewhere. At WashU alone, WashU obviously is an elite private institution. Faculty and grad students are not provided with asymptomatic testing options. I do not get to be asymptomatically tested. And that for students who are doing tests every 2 weeks, I think it's likely that you're not aware of that. But it's not as though testing is going really well in the United States. In fact, a lot of people are denied access to tests. So that is an issue that we should be thinking about and dealing with also in this class. But what I will say about India is that it has an enormous population size. Here you can see India is this blue dot. The United States is this very faint. So these are decades, 1960s to present. I think that this ends in 2019. This very faint orange line at the bottom is the United States. You can see just how many more people India has. This other line is China up here. India has a ton of people. So one question that I had gotten is, is the problem in the United States just the fact that it's such a big country? And there are other big countries like China and India that, I'm not going to say we should base what we're doing off of them. That's not my point at all. I'm saying it is more complex than just big versus little. So if we compare the US to India, despite India being so much bigger, people often say, oh, we have a lot of deaths, we have a lot of cases because we're such a big country. Well, India is way larger than us, and they have fewer cases and fewer deaths compared to the United States, if we can believe any of these numbers. So, there are possibilities for, even in a large country, taking actions that reduce this, the COVID-19 pandemic. Okay, so other people have asked about the sensitivity of COVID-19 tests, if there are more false positives or false negatives. That is an issue, as I mentioned. there are different types of tests. The different types of tests have different sensitivities. Not everyone has published the sensitivity of their test or the false negative rate or false positive rate. So that's an issue. But one thing with false negatives, in any biological test, you can have false negatives and you can have false positives. Sometimes with COVID, it is not a true false positive. It's actually just that you're testing at a time that is outside the window of when you have the viral load that can be detected by the test. It's not actually really a false negative, right? I mean, in practice, it counts the same as a false negative. But what that means is that there are far more times that you could test for COVID and get a negative, even though you very much are infected and able to spread the virus within days of that test. So, I think that's something to be concerned about. And that's why really, regardless of getting a negative test, we still want to encourage people to practice safe behaviors. Someone else asked, if you've already gotten COVID-19 and recovered, do you need to wear a mask? And I'll say to this, similar to what we've seen with the vaccine, is that this is an upper respiratory disease. You can harbor the virus and transmit it potentially, even if you yourself cannot get sick from it. So right now, I would say the best practice is to continue to practice those safety measures and try and prevent transmission. The other thing is with these mutated strains, they're a big cause for concern. In Brazil, many people who had already been infected with COVID-19 have now been infected with the new strain that is circulating there, which is different than the strain that many of us have heard about coming from the UK. So it's not clear yet why that is. It's not clear if it's because it's been a certain amount of time since people were infected, or if it's because of the type of strain that it is, but it's definitely a concern. People asked if testing daily or more frequently is better for identifying asymptomatic cases and reducing spread. Absolutely. If you have a false negative, or then doing more tests will help clarify if that negative truly is a negative or not. You don't have to worry about being outside that detectable window if you're testing regularly. So yeah, I mean, some countries have done a very good job of handling COVID by really regularly testing. Someone asked or several people asked if our nation had more equality and ways to help people who are less fortunate, would we have fared better? And the answer is yes. I mean, hopefully the information in today's lecture kind of pointed out the limitations that certain people faced during the pandemic. A lot of people were asking what countries have done the best. That's really hard. This pandemic is not just about the case count, the death counts. It's also about the other issues that have happened as a result of the pandemic. But if you want to look at case count and death count, I found this graphic that was published out of Australia to be kind of helpful. The US is down here with Iran and Colombia, Mexico, and Brazil. Places like New Zealand that have consistently been in the news as a good example for the COVID-19 response is up at the top. Rwanda also, it has been in the news for really strong COVID-19 response, as well as Vietnam. So, you can kind of see here differences for different countries in their response. Someone asked how you address false claims like that COVID is a hoax or wearing a mask isn't helpful. And to that, I really want to reemphasize that idea of showing kindness. I don't think that we get out of the situation we're in the United States right now by just shaming people or telling them they don't know what they're talking about, or they're stupid, or that they need to learn science and whatnot. I think that we handle that with a lot of compassion, with a lot of kindness, with a lot of patience, and trying to meet people where they are. Figure out what is important to that person, what is something they can understand and identify with, a common ground, everyone can find a common ground somewhere, which really helps explain a situation in a much more personal manner. I've already gone over this one. Someone asked about the large population size in the United States. People were asking if now with the change of administration, if the issues will get better. I hope so, but there are state and local officials also that play a big role in what's happening in this pandemic. And of course, all of us do as well. But I will say, I love seeing people wearing masks in Washington, D.C. That I think setting that culture of safe behavior practices is really helpful. And then I'll just end with this question for now. I'll go over a few more next time. But how do we keep up with safety practices when people are fatigued? It's a great question. And I think, as I was saying earlier in this lecture, if you can try and be creative about the things that you're doing, if you can support each other, if you can find ways to kind of feel connected and feel a sense of community, that's very helpful. And also remember what the cost is. A lot of people making choices that they were sick of being locked in and they wanted to go to a party, or they wanted to go to a wedding or a Thanksgiving meal, and so on and so forth, right? All of these, there's then the news story that comes a few weeks later, like here are all the people that got sick and died because of that. So just remember what's at stake and try, if you can, to be creative about getting through this and take care of yourself, because your health, both your physical health and your mental health, are so important. And one thing that we talked about last time is that you have to remember that your mental health will suffer if when you look back at this time, you feel very bad about the person you chose to be during it. So don't just guard your mental health now, guard your mental health for who you will become as well. And I know that's a hard thing to do. So these are questions that can keep going and that we can keep talking about for a long time. But I'm going to end it here for now, and we'll pick back up next time. So I will see you on Wednesday. Until then, stay safe.